Welcome to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Our focus is the novel coronavirus. I'm Josh Sharfstein, a faculty member at Johns Hopkins and also a former secretary of Maryland's Health Department. Our goal with this podcast is to bring evidence and experts to help you understand today's news about the novel coronavirus and what it means for tomorrow. If you have questions, you can email them to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I speak with Dr. Jennifer Avegno, the director of the Health Department in New Orleans. We speak about how her city went from one of the most affected by COVID-19 to an example of how to achieve dramatic reductions in infections. We also talk about how she thinks about ongoing protests against racism and police violence. Let's listen. So, Dr. Avegno, thank you so much for joining me. If you could take me back to when you first realized that New Orleans was approaching a true health crisis as a result of COVID-19.
Sure. Thank you so much, Dr. Sharfstein, for having me. We had coronavirus on our radar since the beginning of the year. We had been looking at what was coming out of China. New Orleans, being a port city, being a destination city, has seen its share of epidemics since its founding. And so we were very aware. We had begun making plans to do tabletop exercises to revise our own pandemic plan that hadn't been updated in a couple of years. So, we did that. Obviously, Mardi Gras is a big time for us, and the health department spends a lot of time doing first aid stations. So even through that, we were thinking about COVID, watching it. Maybe the first case in Seattle happened sort of mid-February. And so immediately afterwards, after Mardi Gras, the end of February, we had a huge tabletop exercise. We had thought through multiple scenarios of how we thought COVID was going to reach New Orleans. And all of them really involved a traveler from somewhere else showing up and various scenarios. And, we had multiple levels of government agencies, transportation, everybody there. It was a really great exercise. And then, of course, COVID showed up in a way that nobody expected. Our first case was March 9th. We had been waiting for it. We had been expecting it. Our first case was someone who hadn't traveled. So, sort of put that in the back of my mind. The next day, we had two more cases. And I found out quickly that neither of them had traveled and neither of them had had any contact or known obvious contact with the other two. And that was the second that I knew that everything was going to be different, that everything we had thought through very carefully, every other epidemic we had planned for, like Ebola and Zika, this was going to be completely different, and we needed to change our planning immediately. And, fortunately, New Orleanians are no stranger to disaster planning, which means we have really good infrastructure in place. We have good partnerships in place with the state, with the feds, with our Homeland Security. And so for us to pivot that quickly, it was not as difficult as it might have been otherwise.
So what were the keys to kind of weathering the storm as the cases and the number of sick individuals started to rise?
I think really being on top of the data, being able to get accurate data early, to understand really in the first week that we were in widespread community spread, and to shut down as quickly as we did. And, I say at the time it was a really agonizing decision. Now it was obvious it was really the right decision.
Like, how many cases did you have when you decided to shut the whole city down?
I mean, we maybe it was less than 10.
Wow.
And that weekend, it was the third day, we had major parades planned for that weekend. It was St. Patrick's Day weekend. And we made the decision to shut down the parades. And people were furious, didn't understand why. In retrospect, obviously it was absolutely the right thing. And that was borne out pretty quickly. What helped not help, but we got hit very hard, very fast. And so it became very real to most of our citizens that this was serious. And so we didn't have to, explain why. They could see it in their friends and their loved ones. And so the messaging was really more of solidarity. We all have to do this together. How much worse is it going to get? And so I think people took it really seriously pretty early on. And from a governmental point of view, that was incredibly helpful.
And when did you realize that you were going to make it through without a total collapse of the healthcare system? Did you worry about that? I know you're an emergency room doctor. You must have been hearing from your colleagues. At what point did you see that you were coming to the top of the curve?
Right. I still actually practice clinically about once a week. And that was incredibly important for me to understand what was really happening on the ground. The fear was palpable. We came very, very close. And for a few weeks, it was touch and go as to whether or not we were going to be overwhelmed. But each one of the three major hospital systems just started adding capacity here, there, shifting things around. Every day we had, we were either holding on or maybe we had a few more beds. And I have to say, our critical care docs really figured out some of the keys to COVID very early. They figured out the ARDS-like treatment. They figured out proning. They figured out some of the protocols that we now know work a little bit ahead of the curve. And so they always managed to buy us time. And once we hit our peak of cases in the first week of April, I was very well reassured because we still had ample capacity. We never, ever got to that point. And then once our cases began to decline, we've got robust capacity now. We had figured it out, which was a great relief.
And one thing that I certainly noticed is that as you started to come down, you didn't exactly take your foot off the accelerator in terms of, control of the disease.
Right. No, I mean, that's really when we began to ramp up, because I think our steep rise, at one point, our peak, we had about 400, 450 new cases a day. That's in a population of a city of 400,000. So that is a substantial number of cases. We were leading, the country in terms of the rise of our cases. So, we knew how high we could get, and we never, ever, ever want to get that high again. So we have been ramping up testing, ramping up, other efforts as if we're still having 400 cases a day, so that we never get to that point.
Right. And so what are you particularly, pleased with in terms of the response from that time? What have you been working on? What have you been able to accomplish?
Well, I think that our testing has really been a bright spot. We were the first city to open the drive-through testing partnership with the federal government. They called us, I think, the second week we had cases, and they said, "Do you want to do this?" We said, "Yes, absolutely." And in 3 days, we had it done and we opened. Again, that's because we had all these pre-existing relationships and knew how to plan for that kind of disaster event. But we were incredibly grateful for that partnership. It allowed us to flood the city with thousands of tests that we would have had great difficulty getting otherwise. But we knew from day one it was not going to be sufficient. We knew that it presented significant barriers for a number in our population, particularly those who had the least access to testing and were at highest risk because of their comorbidities or their neighborhood that they lived in. And so we very early, we did the drive-thrus for about 3 weeks, but after about week 1, we started designing our own, what would we want to do in an ideal testing? How would we do it? And then as soon as we could, we sort of broke away from the federal government model and started going our own way. And that's really proved to be a success. And it's bred success upon itself. It's really, really grown as people see how well it works.
So let's say you see a little bit of an indication of some transmission in a particular part of New Orleans. The percentage positive goes up, or a whole bunch of cases are in an area. And you think, I really want to understand more about what's going on and respond more intensely. What do you do?
So we pretty much daily look at our results. We look at maps, we look at our testing site results, and we figure out where we need to go, and we figure out a way to get our testing units there. It depends really on where the site is. New Orleans is a city of neighborhoods. I'm a native Most of the people in my departments are native, so we know them really, really well. So if we see, oh, there's a hotspot in this neighborhood, someone will say, oh, that's where this apartment complex is. I know this apartment complex. Let's go test there. And that's been our really on the ground, having that local knowledge has really helped us. For other communities, like our Hispanic community, are not just in one neighborhood, but really early on, we were able to see through our mobile testing sites that their positivity rates were much, much higher than what we were getting in the rest of the community. And so we were able to immediately get business leaders, faith leaders from that community to come together to devise a more comprehensive strategy rather than just saying, we'll go to this neighborhood or that neighborhood.
So it's more than just testing if you're trying to control the disease.
Yes.
What else is part of that core package?
Part of it is when we're doing our testing sites, we have our health department staff and partners on hand. We do, as well as some of our academic partners, we do a needs assessment of everybody who comes through just to see what they're struggling with, whether it's food insecurity, whether it's behavioral health, whether it's trouble getting their medications. And on site, we have some of our personnel who can either directly link them to services, or we have resources that we can give them, but it's a really personal touch. And then we're not, the state health department has the responsibility for contact tracing, but we are calling back everyone who comes to our sites. And again, providing them with that local sort of, how are you doing? How can I help? Oh, your clinic is closed. Where do you live? Let me figure out how to get you to another clinic. More, just a more sort of well-rounded approach, I think, so that the community really trusts us. And when we say, hey, look, there's going to be a contact tracer calling them, please answer the phone because they need to give you some really important information. We feel like folks will maybe do it a little bit more if they know that it's coming from a trusted source.
Yeah, must be quite a moment to be in the health department, to be leading the health department.
Well, if you had told me that I was going to be the person who shut down the bars in New Orleans when I took this job, I would have said that you were crazy. But I'm so grateful to be able to be here. I mean, this is my community. My family has been here for generations, and I would not want to be anywhere else. That's for sure.
I'm sure many of your staff at the health department feel the same way.
Yeah, they are an incredibly hardworking, dedicated bunch. They really are.
So from 450 positives a day, where are you now in New Orleans?
So today we had 7. Our average is about 20. We every couple of days I do a hot sheet for the mayor with just sort of our latest statistics, and we're routinely 95%, 96% down from our peak. And that's where we want to stay. Our positivity rates less than 3%. We are planning, our state has moved into its phase 2 last week. We are planning to move into our phase 2 this week. We meet all of the milestones by a mile, but we are also being more cautious and steady and restrictive because, again, we know how quickly we can snap back. We know the potential for both residents and visitors alike to recirculate or cause a surge. And so we're just trying to take it slow and do it based on science as much as possible.
Talk to me then about the protests that have been happening in New Orleans and how you think about them.
Yeah, I've been really proud, again, of our community. They have been overwhelmingly peaceful. I don't even think we've had any arrests. They've been thousands of people, which, it is a public health concern. So from a pure public health perspective, obviously, we know that gathering sizes are a concern. I will say that the vast majority of our protesters have been masked and have been trying to socially distance as much as possible. And I'm really encouraged by that. But the way I think of it is this, since this pandemic started, we have decided what we consider to be essential activities and non-essential activities. And I think the same applies here. I think that exercising one's right to free speech under the Constitution to protest systemic racism and inequities, which are true public health crises, is a far more essential activity than throwing a birthday party for 200 people in your backyard. And while we really encourage our protesters to be safe and stay safe, and to come and get tested at regular intervals if they feel that that's appropriate, to monitor their symptoms, to not go out if they're feeling sick, we recognize this critical moment in history.
Great. Well, it sounds like you have had just an incredible series of moments in New Orleans, and New Orleans is lucky to have you there.
Oh, thank you. I'm honored to be here.
Thank you for listening to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Please send questions to be covered in future podcasts to publichealthquestion@jhu.edu. This podcast is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Lamare Morales. Audio production by Niall Owen McCusker and Spencer Greer, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.